Welcome to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Avalada from Roots Community Health, reporting for the week of December 22nd, 2025. As health professionals rooted in East Oakland facing some of the widest health disparities in the nation, we're here to bring you timely public health information relevant to us all. This week, we'll begin with an update on contagious illnesses, including a brief look at measles and pertussis, also known as whooping cough. We'll then conclude our long COVID segment with Dr. Aziz Khan and finish with a summary of upcoming changes to Medicaid. First, let's take a look at the current respiratory landscape. To start, we'll review the weekly percent positive chart, which shows the proportion of clinical tests coming back positive for each of these respiratory viruses. Here we see that rhinovirus and enterovirus, the virus most commonly responsible for the common cold, still make up the largest share of circulating viruses. That is depicted in the gray line. However, the margin is narrow as influenza is close behind and continuing to increase its share of respiratory viruses as shown by the upward trend in the dark blue line. Now, turning to influenza trends across the country, we can see that the increase in positive tests is even more obvious. As a reminder, these data are forecast based primarily on emergency department visits, which help give us a real-time picture of community spread. Influenza activity is rising nationwide, as shown by the dark purple shading. Only one state, Hawaii, is currently showing a decline. The three states shown in white, Utah, Wyoming, and Arkansas, are not currently reporting data. This doesn't mean that influenza is absent in these states. Rather, these estimates could not be generated due to either incomplete data or too small of numbers or other reporting issues. But by most accounts, it is likely that influenza activity is increasing in those locations as well. Looking at COVID-19 epidemic trends, we see the growth occurring across much of the country, again represented by shades of purple. California is one of the few West Coast states where COVID-19 is now actively increasing, while many Western states are currently gray, which means stable. The trend in the East and Midwest suggests we should be prepared for a shift in the West Coast soon. Turning to hospitalization data, we see that RSV, shown in purple, and COVID-19, shown in orange, are both increasing only slightly at this time. In contrast, influenza hospitalizations, shown in blue, are clearly on the rise. Flu season is firmly underway and showing no signs of slowing down. We have about 19,000 new flu hospitalizations reported in the past week alone. There have also been 700 additional deaths, bringing the total number of flu-related deaths to 1,900 already for the season. So we are once again stressing the importance of taking precautions to protect yourself against the flu, yourself, your loved ones, and your community. If you would like some tips on how to take these precautions in your household, please check out last week's briefing. And in addition to the usual winter illnesses, we're also paying close attention to measles and pertussis. Measles cases continue to rise across the country. We're getting close to 2,000 cases reported for the year. Staying vigilant and up to date on vaccination is especially important to protect against measles, and this is something to check on now, especially during the holiday season when increased travel raises the risk of exposure. Now turning to pertussis, with cases rising across the country and vaccination rates declining, we want to take a moment to explain what pertussis is, how to recognize it, and how it is treated. We will be providing a more in-depth discussion on this in an upcoming briefing, but for today, this is a brief overview of what you need to know now. Whooping cough is named for the distinctive whoop sound some people make when they gasp for air after severe coughing fit. Early on, the illness can look like the common cold with symptoms that last 1 to 2 weeks and include a runny nose or a stuffy nose, a low-grade fever, so below 100.4 degrees Fahrenheit, and a mild or occasional cough. What distinguishes whooping cough from a normal cold is that the coughing can then worsen rather than improve and can lead to intense coughing fits followed by the characteristic whoop. If you hear this type of cough in a child or an adult, it's important to seek medical care right away so that treatments, including antibiotics, can begin as early as possible. In infants, symptoms can be more dangerous and may look different. Most importantly, is to note that some babies may not cough at all, but instead experience apnea or pauses in their breathing, which can be life-threatening. During these episodes, babies may turn bluish or appear to struggle to breathe. This requires immediate attention. We are most concerned about infants because they are susceptible and it can be particularly life-threatening in infants. Their primary vaccine series is not finished until they're 4 to 6 years old. They rely on population immunity, in other words, the rest of us being vaccinated, to stay safe. Unfortunately, we have seen infant deaths from pertussis already this year, following a national trend of cases reaching their highest levels in over a decade. So again, we'll be discussing this in more depth in the new year, but for now, if you or your child has a worsening cough, please seek medical attention. While we're seeing these immediate and concerning surges in acute infections like measles and pertussis, we cannot lose sight of the long-term health challenges that can sometimes be consequences of acute infections. So post-infectious issues. Since the start of the COVID-19 pandemic, long COVID has become a major global public health concern, affecting everyone from children to adults. As we move into our final segment on long COVID with Dr. Aziz Khan, I wanted to highlight recent findings that further illustrate why this condition remains a critical public health priority. Today, I'll summarize 3 recently published studies on long COVID, 2 of which focus on children and adolescents, a population in which long COVID remains understudied. Throughout this discussion, we will intersperse Dr. Khan, who will provide context and strategies to reduce the risk of developing long COVID. The first study we are reviewing examines the impact of COVID-19 reinfection on the risk of developing long COVID in children and adolescents. What the researchers found was concerning. Children and adolescents who were reinfected, and this was looking at during the Omicron era, had a significantly higher risk of developing long COVID compared to those who were infected only once. This increased risk affected multiple organ systems, reinforcing that long COVID in children is a multi-system condition, meaning it can impact the entire body rather than just a single organ or symptom, much like acute COVID-19. To reach these conclusions, investigators conducted a retrospective cohort study, meaning they analyzed existing medical records to follow outcomes in a group of more than 400,000 children and adolescents. The study also found that the increased risk associated with reinfection was consistent across different age groups. Children had a higher likelihood of developing long COVID after reinfection, regardless of their vaccination status or how severe their initial COVID-19 illness has been. So this does not mean that vaccination doesn't help reduce the overall risk of long COVID, something we'll talk about more in a moment, but rather it shows that even when children are vaccinated, getting infected with COVID more than once can still increase the chance of developing long COVID. While these findings are important, the study does have limitations, and like any good study, it does enumerate those limitations in the article. Because it relied on clinical and diagnostic data, cases of long COVID may be underestimated. Children with mild symptoms, those who did not speak on their symptoms, those who did not seek medical care or their parents did not assist them to seek medical care, may not have been captured at all. In addition, the data came primarily from hospital-linked health systems, which may overrepresent children who already have regular access to pediatric care and underrepresent those with limited access to health services. So taken together, these findings support the idea of cumulative risk, meaning that repeated COVID-19 infections may increase the likelihood of long-term health effects. The study underscores that even when COVID-19 infections in children and adolescents are mild, This does not remove the risk. A mild infection does not guarantee protection from the serious and lasting effects of long COVID. This serves as an important reminder that COVID-19 remains a significant public health concern. And as I mentioned, based on the limitations in the study, we are still likely under capturing and underrepresenting the incidence of long COVID. For children and adolescents, preventing reinfection is an important public health priority, as repeated COVID-19 infections increase the risk of developing long COVID. And this is an especially compelling argument for paying attention to ventilation and excellent air quality in our indoor spaces, especially our schools and other places where our children frequent. And this leads to one of the biggest questions surrounding long COVID: how to prevent it. Before we look at our next study on the impact of vaccines on the risk of long COVID after infection, let's hear from Dr. Khan on the biggest strategies to avoid long COVID.
What's the best way to avoid long COVID? The best way to avoid long COVID is to avoid a COVID infection. Every reinfection with COVID increases the risk of developing long COVID. So our best bet is to maintain practices that will reduce your chances of catching COVID. If you have caught COVID, please rest. Rest fully and longer than you think you even need to if you have an infection. Do your best. Sometimes this is easier said than done. There is data suggesting that using some medications during an acute COVID infection can reduce the chances of developing long COVID. That includes metformin and Paxlovid as well. Talk to your healthcare provider during an acute infection to get more information.
As Dr. Khan mentioned, prevention starts with avoiding infection, but it can also include early treatment. Studies have shown that certain medications may help reduce the risk of developing long COVID, and those include Paxlovid, and that is the drug used to treat mild to moderate COVID-19 in adults at high risk for severe illness, hospitalization, or death, as well as metformin, which is a medication commonly used to treat type 2 diabetes by lowering blood sugar levels. Studies have suggested that metformin may reduce the risk of long COVID, even in people who do not have diabetes. This next study we're going to review examine whether COVID-19 vaccination before infection reduces the risk of developing long COVID in adolescents. And this goes beyond the vaccine's role in preventing infection in the first place. In this study, adolescents were defined as individuals between 12 and 17 years old. About 1,200 adolescents were included, with roughly 700 vaccinated and just over 500 unvaccinated. The researchers focused specifically on adolescents who did become infected with COVID-19. They compared those who'd been vaccinated within 6 months before the first infection with those who were unvaccinated. This allowed the study to examine what is known as secondary prevention effect. In other words, the researchers wanted to know whether vaccination lowers the risk of long COVID even after an infection has already occurred. To answer this question, the study used caregiver-reported survey data to assess vaccination status and the presence of long COVID symptoms among infected adolescents. Vaccinated and unvaccinated participants were carefully matched based on sex, date of infection, and enrollment date to make the comparison as fair and even as possible. The findings showed that COVID-19 vaccination in adolescents was associated with a lower risk of developing long COVID after infection. So this tells us that vaccination does more than just reduce the chance of getting COVID-19 in the first place. It also appears to reduce the likelihood that an infection will progress to long COVID if a breakthrough infection occurs. So in this way, vaccination plays both a primary prevention role by preventing infection and a secondary prevention role by reducing the risk of long COVID effects after infection. While these findings are important, this study does, of course, have limitations. One key limitation is how long COVID was measured, or how long COVID was measured. The definition of long COVID relied on self or caregiver-reported survey data rather than clinical diagnoses or long-term medical follow-up. So this means there may be reporting bias or recall bias because we're really relying on report of the patient or their caregiver, and the results may not fully capture the severity or the duration of symptoms. In addition, the study did not track long-term outcomes beyond the survey period, so it's unclear how long symptoms lasted for many of the participants. These limitations highlight the need for continued research in this area. Despite these limitations, the findings are meaningful, given the significant impact long COVID can have on the health and well-being of adolescents and the limited treatment options currently available. Vaccination remains a very important strategy for protecting long-term health. The study found that vaccinated adolescents who became infected had about a 36% lower risk of developing COVID. So vaccinated adolescents who became infected had about a 36% lower risk of developing long COVID. Taken together, this shows that among adolescents, COVID-19 vaccination not only helps prevent infection, but also significantly reduces the risk of long COVID if an infection does occur. Before we move on to the next article, Dr. Khan will briefly outline 3 broad patterns or camps of long COVID prognosis. This overview will help set the stage for our next study, which looks at how people with long COVID can be grouped based on their symptoms and how those symptoms change over time.
But it seems like there are 3 sort of camps of people with long COVID. Some who have prolonged symptoms but recover over a few months after their initial viral infection. Others develop a chronic condition that improves, but it might wax and wane. It might get better for a while, and there might be periods of time where the symptoms are worse. And then there are those who have an extended period of disability, who might have permanent, severe symptoms. Without further research, we're not able to predict which individuals will fall into each camp.
The third and final article we're reviewing examines how long COVID symptoms change over time in adults by identifying different symptom trajectories up to 15 months after the first COVID-19 infection. This research was part of the NIH's Recover Initiative, which we've covered before on this briefing and is ongoing. And this is following people over time to better understand the long-term course of long COVID. In this study, researchers prospectively followed over 3,500 adults who were infected during the Omicron era, most of whom were not hospitalized, and nearly 70% were female. Participants completed detailed symptom surveys at approximately 3, 6, 9, 12, and 15 months after infection. Researchers then grouped participants into 8 distinct symptom trajectories, essentially patterns showing how their symptoms evolved over time. About 10% of adults met the criteria for long COVID 3 months after their initial infection. Among these individuals, experiences varied widely. Nearly half continued to have high level of symptoms for up to 15 months, while others had milder symptoms or steadily improved over time. The study also found that some people who did not meet the criteria for long COVID at 3 months later went on to develop more symptoms, showing that long COVID can appear or worsen well after the initial illness. Overall, these findings show that long COVID does not follow a single path. Instead, people can experience very different patterns over time, making the condition unpredictable and highly variable. This research is important because it shows that long COVID is not a single experience. People follow different clinical courses, including persistent symptoms, some with intermittent symptoms, or even delayed onset of symptoms months after the infection. Understanding these trajectories helps clinicians and researchers and public health officials design better care strategies, tailor support for those most effective, and plan clinical trials for treatments that are aimed at specific patterns of long COVID. And it also helps shed light on this condition for the general public because it is not always going to follow one predictable pattern. Like all studies, this one has limitations and points toward future research needs. For example, the participants were mostly infected during the Omicron era and may not represent experiences from earlier variants. Surveys were conducted every 3 months, so day-to-day changes in symptoms may not have been captured. The study also only followed people for 15 months, so we still do not know how symptoms might continue to evolve beyond that time frame. More work is needed to link these symptom patterns with biological mechanisms and biomarkers, so those blood tests, which might be able to help us to predict what's going on with long COVID, and long-term outcomes, as well as to test targeted interventions based on these different symptom trajectories. So big advancement in our understanding here. While long COVID highlights the ongoing need for medical care and support, access to that care is shaped by policy. With that in mind, we now turn to upcoming changes to Medicaid. A few months ago, Congress passed PL 119-21, also known as President Trump's One Beautiful Bill Act. This law includes major changes to healthcare policy, including significant cuts to Medicaid. Overall, the bill reduces federal Medicaid funding by about 15%, or roughly $1 trillion over the next 10 years. These changes are being rolled out gradually, with some taking effect immediately and others phased in over the next several years. Today, we're going to focus on the Medicaid changes that will begin to take effect in the beginning of 2026. Starting January 1, 2026, California residents will see several important changes to Medi-Cal, which is California's Medicaid program. Some adults will no longer be able to enroll in full scope Medi-Cal coverage based on their immigration status. This includes individuals who are undocumented, as well as some lawfully present immigrants who are 19 or older and not pregnant. Beginning on the same day, California will also reintroduce an asset check for certain Medi-Cal applicants and enrollees. This means that the state will look at what people own, such as savings or other assets, when determining eligibility. This change may affect adults age 65 and older, people with disabilities, individuals living in nursing homes, and some families who earn too much to qualify under federal tax rules. So we are definitely discouraged to see the asset test returning in California, and California, which had some of the broadest coverage for those with all different residency and citizenship statuses. Unfortunately, all of that is being dialed back now. Another major change taking effect on January 1st, 2026 is the expiration of the Enhanced Federal Medi-Cal Assistance Percentage, or FMAP. This enhanced federal match, which covered about 90% of the cost of Medicaid expansion under the Affordable Care Act, played a key role in expanding coverage to low-income adults. Its expiration will place new financial pressure on states and may lead to further limits on eligibility or benefits. And then later in 2026, additional requirements will begin to affect Medicaid enrollees. States will be required to implement work or community engagement requirements for many adults age 19 to 64 who receive Medicaid. So to keep their health coverage, individuals will need to prove that they are completing at least 80 hours per month of qualifying activities such as employment, job training, education, or community service. States will also be required to reassess eligibility every 6 months, increasing paperwork and administrative hurdles as it is currently annual. This is only a brief overview of the upcoming changes that we are all bracing ourselves for. If you are concerned about how these policies may affect you or your family, it is important to check your state Medicaid website or contact your local Medicaid office for the most up-to-date information. It is also important to remember that these changes affect more than just people directly enrolled in Medicaid. When people lose health coverage, the entire healthcare system feels the impact through increased strain on hospitals and clinics and higher rates of preventable illness. Thank you so much for joining us for this final episode of the People's Health Briefing in 2025. We will be back on the first Tuesday of the new year. Over the next few weeks, our team will be reflecting and brainstorming ways to make the briefing even better in 2026, particularly in these challenging times we are in as it relates to public health. And in that spirit, we would love to hear from you. Please leave a comment on this video, send us an email at admin@rootscommunityhealth.org, or DM us on Instagram to share what you would like to see in the briefing next year. We truly value your input and look forward to continuing the conversation. This concludes today's People's Health Briefing. Thank you so much for joining us, and we will see you in the new year.